Thierry works at KU Leuven in Belgium, and is I don't need to introduce his impact on gynecological ultrasound. Thierry has a lot of experience actually working in South Africa as well in his youth. I mean, obviously that's quite a long time ago now, but he has a vague memory of working in South Africa. And he's going to talk about a really important topic, fibroids. And of course, this thorny issue of understanding, is there any way we can spot the sarcomas, which of course has become a major issue and became a very hot topic of recent years. So I'm going to hand over to Thierry. I look forward to hearing what you have to say, and we'll have a chat later on.
Good morning. I'll say some words about imaging uterine fibroids and about the problem of spotting sarcomas. When talking about fibroids and sarcomas, well, we have to know that fibroids are very common. More than 50% around the menopausal age will have some fibroid somewhere. It's benign, and the management may be either expectant or maybe surgery, and then preferably minimally invasive surgery. On the other hand, sarcomas are rare, very rare, but are highly malignant. And if you find them, you have to treat them surgically by radical surgery. So it's important to make the differential diagnosis. And in 10 years ago, we published a paper, the MUSA paper, about the terms and definition about how to define uterine masses. And we tried in this paper to see what uterine, the ultrasound features were of the myometrium, for instance, of fibroids. And later we also tried to correlate these ultrasound features with microscopy, and that's what it's all about. So starting with well-defined lesions, according to the MUSA criteria, we have to report the echogenicity, and the echogenicity for fibroids may be, well, whatever. It might be uniform or non-uniform, hypo, iso, hyperechogenic, heterogeneous, may have echogenic areas inside calcifications, or irregular anechoic areas inside the lesion too. So that's possible for a fibroid. What is reassuring that it's indeed a benign fibroid? Well, we can say finding of echogenic areas of calcification is the reassuring features, whereas if you see irregular anechoic areas, cystic areas inside the lesion, that is, we have to worry there might be a fibroid hidden in this lesion. So if you see that, you have to be careful. The second feature we see is the shadowing. That's an artifact, in fact, and you may have edge shadowing from the edges of the lesion of the fibroid, or sometimes the whole fibroid is quite calcified and you cannot see through the lesion. Then you will have strong shadowing behind the lesion, or sometimes it's more septal. You might have more fan-shaped shadowing behind the lesion. And what do you have to remember is, well, the more shadow you see, the more reassuring it is. So shadowing is quite a reassuring feature, just as calcification is also a reassuring feature. When you turn on the color Doppler, the typical color vascular pattern of a fibroid is a circumferential vascularization around the myoma. So that's typical. There might also be some intralesional vascularization. The importance of the vascularization in fibroids is that the more vascularized it is, the more likely it is that the fibroid will grow. So it gives you an idea on the growth potential of the lesion. And also the pattern of the vascular pattern of the lesion can allows you to make the difference between the typical fibroid with the circumferential vascularization, just like a French wire salad spinner, whereas in adenomyosis, the vessels do not go around the lesion, but cross the lesion as though there is no lesion. So that makes sense to look at that to make the difference between adenomyosis and the typical fibroids. When you see a fibroid, okay, first you have to know it's a fibroid. Okay, once you see a fibroid, the three questions you have to answer is: where is a fibroid, how big is a fibroid, and how many fibroids do you see? Okay. For the first question, where is a fibroid, we use the figure classification 0, 1, 2, 3 to 7, and that's important, especially if you want to remove it, to see is it in a cavity in a wall or is it protruding outside the uterus. And especially if you have a fibroid in the cavity, it's important to see if the fibroid is almost totally in the cavity, figure 0. Most of the fibroid is in the cavity 1, or most of the fibroid is in the intramural and not in the cavity, because that's easy to remove by hysteroscopy and that's more difficult to do. So that's important. And to do that, I find it easy to use 3D and to use fluid installation. Fluid installation is very simple. You don't need 3D to use fluid installation. But if you have 3D, of course, it's easier to do a proper mapping. Although it's also possible doing 2D ultrasound. The next question is, how big is the fibroid? And again, that's important if you want to remove it. For instance, for hysteroscopic myomectomy, if it's small, if it's less than 1 or less than 2 to 1.5 centimeters, it's quite easy. If it's a big fibroid, it becomes much more difficult, even impossible to remove, certainly not in one step. So that's important. And then the third question is, how many fibroids do you see? And again, it's much easier to remove one fibroid than removing 10 or 12 fibroids at the same operation. So important information you have to put into your report, because these have clinical implications. So moving on to sarcomas. What about sarcomas? Well, it remains a difficult subject. So if you look at the literature over the last 10 years, well, we are progressing, but we are progressing very slowly. But it's important. What is the importance of sarcomas? Well, if it's a sarcoma, you don't want to miss it, because you have to remove it doing surgery with laparotomy. You should certainly not morcellate a sarcoma, because otherwise you have tumors, pieces of tumor tissue all over the abdominal cavity, and the disease will be lethal in a couple of weeks or months. On the other side, you should not overtreat any fibroid as a possible sarcoma, because then you will do radical surgery in anyone, and you will increase morbidity, surgical morbidity, cosmetic, and also psychological morbidity. So it's important to try to make the difference and to detect the sarcoma. There is, I think, one of the best retrospective study about the typical characteristics of sarcoma is by Ludovici. And they showed that sarcomas are in patients after menopause are often symptomatic, are often solitary, solid lesions that are inhomogeneous in echogenicity. Often you have cystic areas, and typically irregular cystic areas. Fan-shaped shadowing is rare in sarcomas. And often the sarcoma is highly vascularized, and the last feature they proposed was the cooked appearance. Well, I must say, having read that the first time, I was not really sure what they meant about cooked appearance. Perhaps I was thinking about cooked ham or so on, but for the veggies it might be more difficult to understand. So I think you can understand it in another way. Another metaphor is thinking about the blue jeans. If you have a blue jeans, a new blue jeans you buy, and you look very carefully at the structure of the denim, you see there is a nice structure of the denim. And after some time, if you wash it a lot of time, then you will have a more washed aspect of the blue jeans, and the structure get lost. And then if you wait even longer, you will have holes in your jeans, and you will have ripped jeans. So in the old times when I was young, so a very long time ago, it was nice to have a ripped jeans, because that meant that you were someone who wore your jeans for a long time. I know nowadays you can buy a ripped jeans in the shop. But coming back to sarcomas, think of that when you're thinking about central necrosis. If you have a sarcoma at the center of sarcoma, because of the lack of vascularity, vessels reaching the center, you will have some more hyperechogenic areas because of edema and hypovascularity. And then if you wait a little bit longer, it will become somewhat more hypoechogenic. And if you wait even longer, you will have really the real hypo or anechoic area, typically irregular cystic area, because of liquefaction inside of this necrotic area. So central necrosis is something we have to look at, and I think it's something that's important to look at. So if you see the cooked appearance, meaning the loss of structure and the hyperechogenic lesion or of area, or at the end stage an irregular cystic area, you have to be careful. It might be a sarcoma. To summarize, so fibroids, usually multiple lesions, sarcoma solitary, the shape round in fibroids, oval or oblated in sarcomas, echogenicity, calcification or reassuring, fan-shaped shadowing is reassuring. Irregular cystic areas are not reassuring. Cooked appearance also, you have to be careful. A lot of vessels is also something that's not so reassuring, and a fast growing lesion is also something to be careful about. And if you look at the vascular pattern, remember the French wire cell spiral, typical for a benign fibroid, whereas a sarcoma has a more chaotic vascularity inside the lesion. Here we have some example of a irregular cystic area of central necrosis. Here you see also these areas, and here you see this cooked meat appearance here, this more whitish area. Okay, so how to cope? I think we don't have to howl with the wolves and to say that any fibroid is a sarcoma until proven otherwise, because otherwise we will overtreat patients, as I just told you. In most cases, it's quite easy to say that's probably a benign fibroid. It's only a limited number of cases that we are afraid we are not sure about the malignancy or benign character of the lesion. Can MRI help? Yes. Well, if you look at some papers, and for instance this systematic review, you have the impression that it's the optimal test, well, it's in practice is not that good, but it helps. It might help, providing that you have a good radiologist who is interested in gynecological MRI. Otherwise, it's not helpful. So it's also very operator dependent, and it's not always that simple for the MRI specialists. They also use some algorithms to try to make the differential diagnosis between sarcoma and fibroids, but it might be helpful if you have a very interested radiologist in sarcomas. Can liquid biopsy be of use? Well, that's something we are currently looking at. You have the circulating DNA. You have possibly immune cells, and the ratio between neutrophils and lymphocytes might be of use. You have also the proteins LDH, CA125, and other proteins that might help. That's still a matter of research. So, well, at the end of the day, well, you have to when you report an opinion, and the opinion is the medium between knowledge and ignorance, and an expert opinion is in fact the same, but it's good to have someone in the department who is interested in that type of lesion, who may help you in the differential diagnosis. So to conclude, well, don't howl with the wolves. We are practicing medicine, so we have to learn to live with uncertainty. That's our life. And as helpline, you have the expert, you have MRI, some maybe liquid biopsy, and maybe in the near future we can use AI. Thank you very much.